have to think about something else. There is no rule of doing surgery again. You will basically going through a cycle. So yes, polyps do recur. Post-op polyps recurrence, occurs in around 40% of patients by 18 months of age in patients with nasal polyps. But these patients, not all of them necessarily symptomatic. So polyps recurrence overall control with a standard of care treatment, surgery and post-op compliant use of topical medication, it's around 85% control, which is good. And it's been also found, this is something that needs to be highlighted, that among the recurrence patients, the patient with asthma, they have 1.7 times higher risk of recurrence. The patient with Samter's triad, ARD, and asthma, they have 3 times higher risk of recurrence. So presence of comorbid conditions carries high risk of having polyps recurrence. And this is where we think outside the books, and this is where the biologic therapy comes into action. So in our field, is relatively a new treatment modality when compared to other comorbid conditions. In 2019, we start to have the first approved biologic therapy and for the treatment of nasal polyps. And the key biologic targets include TSLP, IL-4, IL-5, IL-13, and IgE. As we spoke previously in our T2 inflammatory cascade. So the biologic, they work very well. They treat the underlying pathology and proven benefits in both subjective control and objective control of the disease. And we have a well-established guidelines, and this is the guidelines that is adopted by our Saudi ORL Society. So you have to have a patient with nasal polyps who had a previous endoscopic sinus surgery and has 3 of the below criteria: need of systemic steroid courses, more than 2 courses per year, or contraindication to steroid, significant loss of sense of smell, diagnosis of comorbid asthma, evidence of type 2 inflammation, either by serum eosinophils or high IgE level, significant impairment of quality of life scoring system. We also have a criteria to define the response to biologics. So we evaluate the treatment response after 4 to 6 months. If the patient has no response, we discontinue. And if there is partial or good response, we continue and reevaluate in 1 year. Now the question is, does biologic replace surgery? So the modern concept now is that these 2 treatment modalities are complementary to each other, not alternative. The surgery optimizes the environment, the biologic control the underlying inflammation. In the next 2 slides, we'll have something that indicates this concept. So surgery and biologic is basically the correct term. It's been studied that perioperative adjuvant use of biologics, it helps in the post-operative outcomes. So if you use biologics in the perioperative period, short term, just 2 months, starting 2 weeks pre-op and continuing for 2 months post-op, it's been found that it has significantly better control of sense of smell in those patients. So yes, they basically complementary to each other. Another indication, which is vice versa, if you do an extended surgery, so we have our endoscopic sinus surgery has different types of extension in which how big the openings are. So if you looked at this study, they studied retrospectively 160 patients with nasal polyp patients that has been on treatment for biologic more than 6 months, and they had a prior sinus surgery with different extension. They found that the more extended the surgery is, the better the response to biologic therapy. So they're basically helping each other achieving the better outcome. So like we said before, the biologics are relatively new in our field, and it's been underutilized in our nasal polyps patients. Only 11% of indicated eligible patients receiving biologic treatment. There are reasons behind this, maybe patient-related factors, The type or the mode of administration, the fear of injections might be a factor. The delayed diagnosis, delayed referral to the ENT specialist, lack of infrastructure, and having a trained nurses, a health educator in our clinics also makes a big role when we have a good volume of patients indicated for biologics. So these things are very important. It's been also found that patients are more likely to initiate biologics administered with less frequent dosing intervals. Most biologics maintenance treatment being given every 2 weeks or monthly. Having it as in a more extended intervals will basically keep patients more compliant on these treatment, and this is based on international survey among these type of patients with asthma, nasal polyps, or combined conditions. And by the way, having extended treatment interval has been also proven to have still showing a good outcome, controlling most of our patients. And that brings me to this slide that I wanted to highlight, which is the PROACT concept, which is proper and early initiation of biologics. And this is basically used in different conditions in rheumatoid arthritis, inflammatory bowel disease, which basically states that early initiation of biologics in this subtype of patients of severe disease plays a big role controlling their inflammation. So using it as adjuvant to surgery in a patient who had complete surgery and had quick recurrence of disease, that's a very very accurate hint that this patient is a refractory patient and probably need biologics as early as possible to achieve the best outcome. So in summary, 85% of nasal polyps, they have type 2 inflammation. It's more challenging when associated with other type 2 comorbidities. The standard treatment work very well, but not always. Biologic therapy for severe cases are changing outcome for both nasal polyps and comorbid conditions. Extended treatment interval shows a good control, achieve better convenience and less cost. For nasal polyps, surgery and biologics are complementary to each other, not competing with each other. Early detection of severe disease with early initiation of biologics post-surgery will provide better control of the disease. So that's the end of it. Thank you. And if you have any questions, not sure, Dr. Adib, if you wanna.
Are we gonna? If you are still gonna be with us, we can keep it at the end.
Sure,
it's okay.
Sure. I'll be there, inshallah.
Okay. Thank you so much, Dr. Yazid, for this excellent and very comprehensive overview. It's amazing. You clearly remind us that CRS with MV is not a simple nasal polyps disease, but actually it's more of a chronic inflammatory condition with a major impact on the patient quality of life, smell, sleep, and healthcare utilization. I think one of the key messages from your talk that recurrence after standard care therapy, standard therapy that we do with patients with CRS with MP should make us pause and ask whether we are dealing with uncontrolled inflammation, especially type 2 inflammation, rather than we are dealing with a local surgical problem. Clearly, your lecture highlighted the importance of recognizing the full patient journey from the delayed diagnosis to repeated medical therapy, repeated surgery, and despite that, you have refractory patients. And these refractory patients need more personalized approach, including biological therapy. This fits very well to tonight's meeting, which is really, you mentioned in the last 2 slides, being a proactive and thinking when the early initiation of therapy, of biological therapy in patients who is really in need. So again, thank you, Dr. Yazid, for this. This is clearly and nicely set the stage for our next talk, which is going to shed the light on the type 2 inflammation in the airways. Let me introduce my dear colleague and friend and very prominent figure in the field of allergy immunology, Dr. Prof. Randal Arnaout. She is a professor of medicine in Al Faisal a professor of medicine at Al Faisal University, and she is a section head and consultant of allergy immunology in King Faisal Special Hospital in Riyadh. She's gonna discuss with us the type 2 inflammation in the airway. So the floor is yours, Dr. Arand. Dr. Arand? Are you with us, Dr. Arand?
Okay. Thank you, Dr. Adib, for this nice introduction. We've been meeting a lot and talking about type 2 inflammation recently. It's one of the topics dear to our heart because it is what we deal with on daily basis. So I will share with you my screen and then start my talk. So basically, type 2 inflammation in the airway is very important concept, and probably the United Airway is a concept that is relatively old, but we are revisiting it again because what we used to talk about before, that whatever happens in the nose or the upper airway translates also in the lower airway. And now in the recent year, with the discovery of many good biologics, now we know that the inflammatory pathway that take place in the nose also takes place in the lung, and that leading to chronic allergic rhinitis, chronic rhinosinusitis with or without polyposis, and bronchial asthma in the lower airway. So these are my disclosures. And as we are talking, is that type 2 inflammation is actually a chronic condition, and it is a disease. It is an inflammatory type of disease of what we call it type 2. That means we have a certain type of cells, certain types of cytokines in relation to these cells are produced and also augmented by these cells, and also this type of inflammation can be reflected in many organs. That's why these type of diseases we can call them one disease that is reflected in multiple organs, including asthma, aspirin or exacerbated respiratory diseases, allergic rhinitis, chronic rhinosinusitis, atopic dermatitis, food allergy, eosinophilic esophagitis, and the list is growing also. These patients has a more severe disease when they have the other comorbidities, and they have also higher use of medical attention and need for oral corticosteroids or systemic steroids. There is biomarkers that are important for type 2 inflammation, in particular peripheral eosinophilia, especially when the number is more than 150 cells per microliter, and also they are one of the biomarkers is high serum IgE and increased FeNO production due to the eosinophilic inflammation. And once you find one type of type 2 inflammation, you might need, if it's already not present, to look for the other type 2 inflammatory disorders. Sometimes the people, the patient, we are a little bit tunnel vision. We take care of only one organ and we don't ask about the others, but they are highly associated with each other. So really we need to pay attention so that we can hit all the targeted organs. The patients who have, who have a chronic rhinosinusitis and had a surgery, like my previous Dr. Suleiman was talking, still have recurrent polyps, and this is a problem. And for example, this patient, my patient, 52 years old, referred for primary care with nasal congestion, sinus pain, had prior surgery for chronic rhinosinusitis, on inhaled inhaled corticosteroids or intranasal corticosteroids. Patient also had allergic rhinitis long standing. Clinical investigation showed that with endoscopic shows presence of bilateral polyps, significant restriction of the airway visible on CT scan, and it confirmed the recurrence of chronic rhinosinusitis with nasal polyposis. He's still on intranasal corticosteroids and oral corticosteroid pairs for chronic rhinosinusitis exacerbations. He had a fist surgery or functional surgery to remove the nasal polyps. He had oral corticosteroid spares, as we said earlier. This patient complaining of lack of smell and nasal congestion. And these two factors actually are the ones that most affect the patient quality of life because of the congestion. They cannot sleep, and the lack of smell, it really diminish their enjoyment with food, or even it might be dangerous that they cannot smell like, for example, something burning. So the investigation in endoscopy and CT scan showed the presence, as we said, of bilateral polyps confirmed with the CT scan. It was a recurrence, and there was significant restriction of the upper airway visible on the CT scan. So such a patient, you will think, are we going to go for another surgery, or should we start him on biologics, or should we repeat the surgery and start biologics? So we really, in that matter, we are in multidisciplinary care for these patients with our colleagues in the ENT. So the recurrence is usually driven by type 2 inflammation, and 40% of the patient experience nasal polyp recurrence within 6 to 18 months of the surgery and are retreated again with steroids intranasally and orally. And up to 59% of these patients with recurrent undergo revision surgery again. So basically, this is a vicious circle in 59% of the cases where the quality of life, despite being improved for a little while, they need to have a revision, and then they might need steroids again and again. So when these patients we have to understand that this is a type 2 comorbidity, and a type 2 biomarker usually we can find in many patients high eosinophilia in the peripheral blood more than 150 and above. But even if the lack, because these patients need a lot of steroids sometimes, you might still not have the high amount, but the patient pathophysiologically in the nasal polyps, they have a lot of sheets and sheets of eosinophils in their pathophysiology. So let's take a look at the type 2 inflammation from the very beginning, from the top, from the epithelium, all the way down to the remodeling by the fibrous tissue formation. So basically, type 2 and the cytokines that are involved. As you know, there are epithelial cells. The epithelial cells will be exposed to different types of outside exposure. And this will affect even the tight junction, and then there will be leaking of the antigens to the antigen presenting cells, which and then secretion of the alarmins. The alarmins that are secreted will actually, by the epithelium, will ask the Th0 or T helper cells and or innate lymphocytes to differentiate into type 2 cells or innate lymphocytes type 2. And these will, and the Th2 cells will produce the IL-4, IL-5, and IL-13. The role of IL-4 and IL-13 to go to the plasma cells and ask the B cells to class switch and start producing IgE. The IL-5, on the other hand, will ask the plasma cells to actually will go and recruit eosinophils into the tissues, and also will help the maturation, differentiation, and migration of the eosinophils into the tissues, building up an eosinophilic inflammation in the tissues. This eosinophilic inflammation also, in addition to the IL-5, will need an IL-13 to be trafficked further and further to the tissues. And under the effect of the type 2 inflammation, there will be goblet cell hyperplasia and fibrin deposition, mucus secretion, and mucus plugging. And in case of asthma, there are smooth muscles there, so there will be a smooth muscle hyperplasia, and which is the remodeling we see. But the form of remodeling we see in the nose is actually the formation of the polyps, where the eosinophil gets trapped in the fibrin. So there is an impaired epithelial barrier, which is more susceptible to the damage, and this damage gets worse when the IL-5 is secreted in high amounts, in addition to the other type 2 inflammation cytokines. And the repair response will be actually disabled or deficient in the case where we have high amounts of these cytokines. And of course, this this will lead to the whole pathophysiology of the type 2 inflammation, from the impaired barrier to the remodeling and formation of the fibrin deposition and limitation of airflow, or actually polyp formation. So chronic rhinosinusitis, we have been talking earlier, that is an upper airway chronic inflammation, and it's a persistent condition. It's not something that you have and it will go like an infection after taking a course of antibiotic. It's there to stay, okay, unless you really need to shift or shut down that inflammation. And the inflammation in chronic rhinosinusitis could be of type 1, type 2, or type 3, but in 85% worldwide, it's of type 2 type. And actually, there is a study, I think, in Saudi Arabia by the university, where it showed that it might be 95% of our nasal polyp patient is of type 2. And as you know, IL-5 is a central mediator, in addition to IL-4 and IL-13, in the driving this type 2 and actually augmenting it further and further. The persistence of inflammation will lead to further epithelial damage, to nasal polyp formation when the eosinophils are trapped in fibrin and it will form, and the symptoms will establish, including the congestion and affection of the smell. So the type 2 cytokines that we have been talking about is IL-4, IL-5, and IL-13. Each one plays a very central role, but also has a different role in the whole pathophysiology of this eosinophilic inflammation to a large extent. You need pathophysiologically the barrier disruption that we talked earlier. You need the infiltration of the cells. You need the cytokines to produce hyperplasia of the goblet cells and the mucus production, and fibrin deposition to have the nasal polyp formation. This will all lead to the congestion, rhinorrhea, difficulty breathing, reduced smell, facial pain due to the filling of the sinuses with fluid, thick fluid, and of course this will lead, because even with surgery the inflammation is still there, although we are removing the polyp. Yes, we reduce it, but still there's a good chance of recurrence despite the surgery. So IL-5, which we say that it plays a central role, it is actually mediate the epithelial barrier dysfunction further, and also the recruitment of more eosinophils into the tissue by helping in their maturation, proliferation, and migration through the blood and all the way to the tissue, and leading to the also immune cell dysfunction, where more and more cells are recruited into the area, whether it's or even other cells, and also the remodeling of the airway and formation of the polyps. This excess mucus and change in its properties, it leads also to the olfactory dysfunction, and there is like a lot of studies now on the immunopathological impact of type 2 inflammation on the olfactory function in the nose. So IL-5 is a critical cytokine in type 2 inflammation and leading to different manifestation. It is multifaceted. one cell that is very important or can be a biomarker in all kinds of inflammatory pathways, I would say it's the eosinophils. Eosinophil survival, yes, it is mediated by the IL-5, but it's not necessarily reflecting only type 2 inflammation. In case of chronic rhinosinusitis with nasal polyposis, in a vast majority, it reflects type 2 inflammation, but also it's a bivotal or multivotal cell. So really we need to look at it in a more deep fashion than just it's a simple part of the of type 2 inflammation. Higher levels of IL-5 as usually leads to higher rates of recurrence association, big time association, and elevated IL-5 is also associated with severe manifestation of chronic rhinosinusitis. And the whole pathway, the type 2 pathway, promote, of course, the excessive olfactory dysfunction and mucus production. So basically, it's very important sometimes to block the pathway directly or indirectly in order to stop the polyp formation. But in case of the blocking the IL-5, you probably shouldn't do it in an earlier stage than later, because when a lot of remodeling is there, your response will not be the optimal or the one you want. And in this case, it will be an excellent thing if you will start thinking about interfering earlier on. So IL-5 correlates, as we said, with severity and high recurrence of nasal polyposis, and of course the need for further and further surgery. Like I told you earlier, around 59% needs to have a revision surgery. And actually it reduces the barrier integrity, so that we have a genetically predisposition with a barrier problem in the patients with type 2 inflammation. But on the other hand, the IL-5 comes and makes this even more and worse, by it acts on the epithelial cells, altering the gene expression and weakening the tight junction and increasing the epithelial permeability. And with the disruption, this disruption actually enriches the expression of the genes that are responsible for the epithelial barrier, like the filaggrin, for example, gene, and also suppress those that restore this damage. So it's very important to shut down or decrease the amount of IL-5 produced, so that we can control the inflammation in this case. It's a fundamental, also interleukin-5 is fundamental for tissue remodeling, and is linked to the basement membrane thickening and fibrosis, and even bone formation by activating the fibroblasts. So it's not only important in recruiting eosinophils, but also expression, the receptor is expressed in fibroblast and result in both directly and indirectly activation of the myofibroblast differentiation, leading to ACM deposition and epithelial fibrosis in the chronic rhinosinusitis, for example, and nasal polyposis. So we have type 2 inflammation, we have nasal polyp growth, and then the remodeling starts with the, and we go into a vicious circle with a lot of rhinorrhea, nasal congestion, and like a nasal blockage due to the presence of nasal polyps. And when you remove it, it comes back again. So it's important for the creation of the polyps, but also it plays a great role in recurrence of the polyp at the same time, with all the the manifestation and what affects on the quality of life due to the manifestation itself. So I will go to the united airway concept, that upper airway and airway are connected and they are not separate. We cannot say you breathe from your nose, but your air goes into the trachea, so your airway starts from the trachea. No. And this is the concept we have been advocating in the field of allergy immunology for a very long time. And luckily, the other subspecialty has adopted it because it makes a lot of sense, and actually it's well connected in every way. So in a multi-national registry study, most of the people with severe asthma had an eosinophilia in the peripheral blood of 150 and more, and actually their response to treatment was associated with more and more, with the higher eosinophilia, the better response to treatment. And in this registry of 1,700, around above 1,700 patients with severe asthma, according to the likelihood to having eosinophilic phenotype, actually, only 28 patients had a non-eosinophilic phenotype, and the rest had eosinophilic. So the vast majority of the patients, and we know this from before, that are eosinophilic. And this was multi-center in different countries, and no matter which country, the list was maybe in South Korea, where 64%, but you can go up to 93% in Denmark, where it's mostly eosinophilic asthma. Eosinophilia was responsible for the severe asthma. And blood eosinophilic count, and I just told you earlier that it has a prognostic biomarker in severe asthma. So it's very important and underutilized in clinical practice. But now we actually, it has been always to save money or whatever. In many centers, they do CBC without a differential. But now, even in simple, in case of asthma, not only for infection, we need to look at the eosinophil count, because it means a lot to us to phenotype different diseases. So blood eosinophil, quick, simple, easy, accessible in most places if they order it. Despite this, 51% of patients with severe asthma in China underwent a blood eosinophil test only. So that means another 50% did not go do an eosinophil count. 62% of patients in primary diagnosis in the US only had serum eosinophil, so a little bit higher. And 20% only of patients with a primary diagnosis of asthma in the US received no biomarker testing at all. So that means that this is underutilized, and probably 2/3 of, as we said, up to 90% in certain areas, it's eosinophilic, but nobody is looking at it, or actually a humble number is looking at it in some areas. So you probably it is something simple and easy to do, and it should be done. So we have there is a guidelines for actually even allergic rhinitis. We're looking at area guidelines, which asthma, allergic rhinitis, and its impact on asthma. So what happens in the upper airway translates in the lower airway, and they talk to each other. So asthma, when it's comorbid with chronic rhinosinusitis, it has a lower lung function, lower quality of life, lower control of the disease, and higher impact on the patient's day-to-day activity. So patients in here, they have patients with chronic rhinosinusitis and with asthma have definitely their FEV1 is worse than the patient who does not have nasal polyposis, who does not have asthma with the chronic rhinosinusitis. So nasal polyposis is usually bad for asthma bad for chronic rhinosinusitis, nasal polyposis. So, and it's usually nasal polyposis associated with worst asthma control and the most frequent asthma exacerbation, as it shows in this study. So in the association between nasal polyps and the frequency of exacerbation in adults, the patient with percentage who had nasal polyps had the highest, the higher number with more exacerbation when they had those who have a higher percentage of nasal polyps. So basically, if you have, that's why the SAMTER triad patients that we see in our day-to-day clinics usually are the worst. Those have severe asthma, has nasal polyposis, aspirin sensitivity or NSAID sensitivity. They are the worst patients that you can have, and they have frequent exacerbation. These are those who need surgery, and you should think about using the biologics for them as soon as possible. So how do we treat with anti-IL-5? as one of the treatment option in this case, because anti-IL-5 inhibits or reduction or inhibition reduces the epithelial damage. So talking about restoring the barrier defect, our loss of integrity and severe asthma, and this will start decreasing the inflammation from before. And if in the Mezelico study, they looked at the patient before the IL-5 and 12 months after the IL-5, and you can see the high proportion of intact epithelium in this stain after treating the patient. So it plays a role in, like we said earlier, it helps the damage, and when you block it, it really helps the epithelium to regain its integrity, and which is important to shut down the inflammation downstream. And it also reduces the mucus plugging, leading to improved lung function in patients with severe asthma, as you can see here. So these are the patients who have been, after 12 months of the use of anti-IL-5, who had no exacerbation whatsoever. So basically, the one with the severe, with the high exacerbation or the high frequency of exacerbation actually vanished. So basically, there was no mucus plugging is associated with markers of type 2 inflammation, and actually with the higher eosinophil count, there will be increased mucus plugging in here, as you can see. And also when the mucus plugging is reduced, there will be less airflow impact on the airflow, and this number of patients who had mucus plugs. So basically, there will be, this shows us that even with the mucus plugs in the high resolution scan before and actually after it will be reduced after 6 months, and after 12 months the patient FEV improved and there were less exacerbations. So also we talked about the smooth muscle area and the remodeling that happens in the basement membrane, and the biopsies has showed also that the airway smooth muscle area, this is a pre-treatment, and look at the stained area after 12 months, how much reduction there is in the stain. That means in the smooth muscle hyperplasia. And if you look at here also for reticular membrane thickness, this is the pre-treatment look at this area, and then after treatment this area has cleared from this, so from this thickening. So basically, even on the basement membrane and also on the smooth muscle hyperplasia, if you shut down the inflammation by using the anti-IL-5, this showed us that also have impact on the smooth muscle fibroblast and also the remodeling that happens later. So reduction in the remodeling is associated with IL-5 inhibition and also with clinical improvement. And here in a 3-year treatment study, they looked at the airway smooth muscle and area, and there was a reduction from 27 to 22%. The airway smooth muscle layer thickness from 0.03 to 0.17, and also the damaged epithelium from 27% to around 10%. And the basement membrane, sub-basement membrane thickness from 10 to 7.8, and also the submucosal eosinophil count went from 7.1 to 3 per millimeter square. And this shows us that the inflammation and the remodeling and the basement membrane changes and the smooth muscles has been reduced with the treatment over 3 years. Similar is even in the 1 year showed that there was 60% reduction in severe exacerbation, increase of EV1 from around 70% to 80%, and increase from of 3.5 in the mean ACT score. That means the control test. So statistically significant improvement clinically after 1 year. And when you look at even the pathophysiology or the pathology after 3 years, biopsy shows us that even on the long term, there are improvement. So IL-5 in type 2 inflammation, there is still unmet needs, and there are new options coming in the horizon. The one problem that most of the injections now every 2 weeks or every 1 month or 4 weeks, and that's sometimes after some time patient maybe improve in the beginning, but then they get fed up a little bit and they want something that has a longer life. On the other hand, also sometimes we have a delay in the interference, which the patient damage already has happened, and interfering late is usually doesn't help as much as optimally like we are expecting. So there will be, with the delay in the interference, actually there will be a poor resolution of the inflammation and the tissue damage. So and we have been seeing that there are a lot of delay in the biologic initiation, and actually reluctance from sometimes physicians and also from the patient fear sometimes if you don't talk with them. And of course, the disease doesn't stop, it progresses. And there is always nice window after the first endoscopic surgery to interfere where the inflammation has been suppressed because of the removal of the inflamed tissues on the polyps. And if you interfere or initiate the biology, probably you will inhibit what comes later, and you will prevent the recurrence, and of course the possible steroid base that can come later. If you have the current biologic that we are having. But still there are unmet needs. Like we said, most of the biologics we have are short acting, are add-ons, so we have to wait until the patient reach for example in asthma stage 5 before we can start it. So approximately 40% of patients with chronic rhinosinusitis remains uncontrolled despite the surgical intervention. Biologics are underutilized. 12% only of eligible patients are treated. Frequent dosing may be a barrier, and that's why the patient, it's not easy to be injected every 2 weeks or even every 1 month. And that will lead to adherence problem, complex. They frequently ask when I'm gonna stop. So patients want a rapid relief, want to stop their problem, want to avoid surgery, but also the frequency of the medication is usually a problem. On the horizon, we have something that is given every 6 months. It's a dipimokinab, which is the first ultra long acting monoclonal antibody with enhanced IL-5 binding affinity, high potency, extended half-life, probably enable twice yearly dosing every 6 months, and actually enhance, as I said, IL-5 binding affinity and potency, and very potently, and will shut down the downstream of type 2 inflammation mediated by IL-5. And actually this increase in the binding affinity and reduce the lysosomal degradation and promoting recycling back into the circulation. That's its engineering will be very promising, hopefully, in shutting down the inflammation long term. Sometimes in the old times, the people used to come in the beginning of the especially in the private practice, to the physician to take one steroid injection, which stays there for 6 months, but with a lot of cost and the side of the side effect. Now we have this one, and hopefully it will act as long as the depot steroids, but without the side effects. So this molecule will leverage the body's natural recycling of the IL-5 pathway and extended half-life. As I have to say that it's not approved yet in Saudi Arabia. I think it has been approved last month, I think, in the United States. And a lot of people has read about something coming that is every 6 months for asthma. And I think this will be a great hope for patients who step down from the frequency of the current biologics that they are on currently, if not on naive, but maybe also it can be a good one for starting early on before the patient get worse. So with less frequent dosing, we are offering the patient solution for we can more likely to initiate with less frequent dosing. Patient demonstrate maybe a higher adherence to the biologic, and with sustained suppression of the inflammation only twice yearly, maybe will stop the recurrence of the, for example, nasal polyposis, and for the lower airway, the remodeling in the asthma. So we are left with early initiation so that we can and use the window that is there before the polyps recur or the asthma becomes advanced. So ongoing trials on different aspects on this depot mechanism, which is anti-IL that is ultra long acting on severe asthma. There are multiple studies on chronic rhinosinusitis with nasal polyposis, Anchor 1 and Anchor 2, on AGPA. And you know that mepolizumab has been approved in AGPA. And hypereosinophilic syndrome, as we said, eosinophilia is not only a marker for type 2 inflammation, it can be also a marker for a more serious even conditions like AGPA, where there's vasculitis, autoimmunity, or hypereosinophilic infiltration with abnormal infiltration of the COPD. So there is a trial on this one for all of these, and we are hoping for the best. I'm happy that I am breaking this good news to into our medical field, and we are looking forward to participating in some of these trials. Actually, we are getting into it. So in summary, IL-5 plays a very central key role in airway, upper and lower, chronic rhinosinusitis in the upper with nasal polyposis, and severe asthma in the lower. IL-5 inhibition can impact the structural abnormality and the immunological abnormality, prevent the nasal polyp formation, restore the integrity of the epithelium, and prevent tissue remodeling, and suppress the type 2 inflammation in general, and suppress the excess mucus and production and olfactory dysfunction. And our improved understanding of IL-5 biology will raise the question as to whether timely intervention, early intervention, beforehand intervention can prevent disease progression and modify the disease course, and for the better of our patient. And with this, I thank you for listening.
Thank you so much, Dr. Ravand, for this excellent and insightful talk. We spared few minutes. That's a good thing that gonna help us. We have a lot of interesting questions actually for the discussion at the end, inshallah. During your talk, you help us truly to connect the clinical picture of CRS with MP, and then the lining biology that is associated with it, and the role of type 2 inflammation, and specifically IL-5 that drives basically a hallmark of inflammation and eosinophil, which lead to persistent symptoms and even remodeling. One of the key, I think, important message in your talk, when the patient has relapses after surgery or continue to need repeated steroids, we should not look into the nose alone. It's more than that. It's actually, as you mentioned in your talk, it's united airway. A full airway should be looked at from the nose in terms of allergic rhinitis all the way to the lung, looking for asthma and COPD and other comorbidities related to type 2 inflammation. So basically, your lecture reminded us that identifying type 2 inflammation disease is not just an academic exercise. Actually, it's a real practice that we see it in our day-to-day life. It's a direct effect how we assess our patients, how we refer between us, between general practitioner like internists or family physicians, to the highly specialized ENT and allergist, immunologist, and pulmonologist. To decide which is the best treatment. So again, thank you, Dr. Arand, for highlighting the importance of treating CRS with MP as part of broader inflammatory airways disease. This leads us to really go to the next session and discuss what's the next. And actually, I would like also to thank you for shedding the light on the new upcoming to Horizon, which is ultra long monoclonal antibodies that really gonna start and giving hopes for our patients. So without further ado, I would like to introduce from Riyadh, all the way from Riyadh to Medina. I would like to introduce our next eminent speaker, Dr. Badr Alam, who is a director and consultant of rhinology and is endoscopic skull-based surgery from National Guard Health Affairs in Medina. And he's a rhinology, head of rhinology committee in there. He's gonna take us from evidence, data, research, all the way to the practices of chronic rhinosinusitis nasal pulposus. I know pretty sure Badr, he's one of the people that he bring videos. So I'm pretty much, he had some videos that gonna show us tonight. So Dr. Badr, the floor is yours.
Thank you so much for the kind introduction. It's always great to share the podium with all of you guys. Really very comprehensive and excellent review by Dr. Arnaout. I would like to share my slides here. And then we're going to talk about are you able to see my slides?
Yes, we are. Yes, we are.
Okay, excellent. Thank you to Dr. Balkhi for the introduction. Thank you for the co-speakers for amazing talks and paving the way for me to do my part on evidence to practice in CRS with nasal polyps. And thank you to GSK to organizing this excellent event. I think organizing such events help us, especially as clinicians, especially as surgeons, more and more to understand these biologics that are coming every day, new indications, new biologics, new population. And we as surgeons are not very familiar with the medical part of rhinology by training. So even to us, it's a very good learning opportunity from our colleague immunologists to see how to actually personalize these biologics to the patients. I saw there was one question asking about the personalized medicine. I think we're going to talk about this in the Q&A session. But I think for me specifically, one of the big things that I really enjoy is that understanding all the pathophysiological breakdown by the colleague allergists helped me to really understand how to personalize it as a practitioner to my patients. I'm going to talk about evidence to practice. So we're going to talk about a little bit about the evidence on the anti-IL-5s and then some of the insights on managing type 2 from a clinical perspective. Some of the videos, as was mentioned by Dr. Balkhi, to kind of laying out for everybody who are surgeons or non-surgeons like allergists and respirologists, to let them see kind of what we see in the offices. And I believe we have the luxury of seeing the gross phenotypic changes of the pathology and inflammation. And I would like to share, I always love to share these videos so that you guys also see the phenotypic changes that happen when the endotypic changes happen at the cellular levels. And then we're going to wrap it up with some home takeaways. So Synapse study was the landmark study that led to all of this, all what we're talking about. It was a randomized control trial, that showed actually a very significant and good improvement in lots of outcomes, but mainly the main outcomes were nasal polyp size and nasal obstruction. It has shown a great improvement without further surgery in those patients. Back in 2021, when these studies came to rhinology world, it was almost Chinese to us to have a polyp reduction without an oral steroid. And no other medication could do that. And in order for us to do that without surgery, we had to give the patient oral steroids to see that happening. So it was very interesting for us to see that a pretty safe medications can do similar or even greater effects in our patients. So in the SYNAPSE study, actually they studied a lot of parameters. One of them was the SNOT-22, which actually basically shows the subjective part of the disease. So there was like 30 points change in the treatment arm between the baseline to 52 weeks into the treatment. And 30-point change is a significant change on SNOT-22. And just to put things in perspective, the MCID score of SNOT-22, that means the minimum clinically important difference that has to happen on SNOT-22 for this difference to have some clinical meaning is set to be 9-point change. So if you have 9-point change by any medication or surgery, this means that this change is clinically significant. So MIPO actually showed about 30-point change, which was very good to see on a subjective point. Now, going into the objective, going into the things that we see on the scope as surgeons, the nasal polyp score. There was around 0.7% change. I mean, if you put it around 1 point change in nasal polyp score over 52 weeks, if the nasal polyp score was grade 2, it became grade 1. If it was grade 1, it became grade 0, and so forth. We're going to break down in the coming slides in which patient population was the change even more obvious and granular. So this is what was interesting. So when they broke down the efficacy, they found out that the patients who were more eosinophilic, more than 150 eosinophils in the peripheral smears, had much more polyp reduction when treated with MIPO compared to those who had less than 150 eosinophils. And though they actually went furthermore, and they found that when the patient would have an eosinophil count more than 300 in the peripheral smears, the polyp score would change by more than or equal 2 points, which basically sends a clear message stating that the higher the eosinophils level, the greater the efficacy of the medication. And this is just a quick point and a quick glimpse about the personalized medicine. So not all biologics are great for all patients. And if you give a biologic to all patients and expect the same response, then of course we're not talking about personalized medicine here, because these data from these studies, these breakdown data, these post hoc analyses actually tell us which are the tailored patients for mepolizumab in our case, who would benefit the most. So as this post hoc analysis tells us, the higher the eosinophils, preferably higher than 300, the better the response on mepolizumab, as was shown in this post hoc analysis. The thing that I really love about mepolizumab as a surgeon is the fact that Martin de Rosier from Montreal actually published in IFAR the discontinuation period post the 52 weeks. So what happens after that 52 weeks? All of us see the graphs up to the 52 weeks, and then we don't know what happened to those patients. Now, there are some data coming about all the phase 3 trials, the post-discontinuation data. But the data regarding the mepolizumab actually showed something that we love to see in our patients keep on asking us on almost each visit. And the fact is, when the mepolizumab was discontinued after 52 weeks, the effect remained stable for 24
Even change the
weeks.
number on her iMessages to the Saudi one.
Sorry?
Sorry, go ahead, Dr. Badr, go ahead.
Sure. So the fact that the sustainability of the effect post discontinuation was actually something fascinating, because we have seen in other trials, when you stop the medication at a certain point, the graph quickly starts to go up back again. But in the MIPA trial, post 52 weeks, sustainable effects for 24 weeks afterwards was pretty interesting to see, and pretty encouraging data to counsel our patients with when they ask us of when should I discontinue or what happens when I discontinue. Now, Synapse study also stated that there is 75% reduction in oral steroid use in the treatment arm. And I always try to put things in perspective, and we as surgeons usually do not use oral steroids long term. Very different from some pulmonologists who sometimes keep these patients, or some rheumatologists who keep these patients on oral steroids for a long time. We usually use oral steroids on a rescue base. When the patient is really going downhill, we give a rescue dose, short term, like 10 days to 2 weeks max, a tapering dose, and then call it a day. So this was a very interesting study by colleagues from the US and Europe, which actually did a retrospective review on privately insured patients in the US. And they studied over 1,500,000 patients, evaluating the frequency of prescriptions for short-term oral steroids and associated adverse events. So how many patients receive short-term oral steroids, and do these short-term courses have any consequences? We're not talking about keeping the patient for 6 months on oral steroids. We're talking about these small little rescue doses. Do they have any problems? And so what they found was very interesting. They found in the registry of over 1 million patients, about 21% of patients received more than or equal 1 course of oral steroid short-term on the past 3 years. So this means that around almost a third of them received 1 or more course of oral steroids. And then, so does this have any meaning? They found that even the short-term treatment with oral steroid was associated with increased risk of side effects, aka 2 times increased risk of fracture, 3 times increased risk of venous thromboembolism, 5 times increased risk of sepsis. And so this tells us the importance of this information, that mepolizumab made 75% reduction in the use of oral steroid. To us as surgeons, knowing this information put things into perspective, that even not needing to give the patients short-term rescue dose of oral steroids actually has great significant benefit for the patients in reducing all these risks of fractures and sepsis and whatsoever. So it's not only about the long term, it's also about the short term. Now I'm going to take you to a little bit of practice. So usually what happens in our rhinology clinics is that we receive those patients who are very sick, type 2 eosinophilic patients with severe nasal obstruction, blocked nose, cannot smell, hardly can breathe, tight chest, probably aspirin sensitivity, and so forth. They usually don't respond to topical steroids preoperatively. So what we do, we take them to surgery and we try to open their sinuses completely in an attempt to allow the topical steroid rinses, which are safe alternative, to go into these sinuses and try to control the inflammation, and later on try to achieve a remodeling effect. But usually with these really high eosinophilic patients, what happens is, if the patient missed the follow-ups or did not strictly comply on the treatment, usually what happens is that they recur severely and quickly back again. And so in the past, we used to take them for another surgery, do a bigger drill out in their sinuses in an attempt to create bigger cavities. But nowadays, we give biologics for the candidates after the MDT counseling, and then they usually recur back to a controlled state of inflammation. So this is what happens. Now I'm going to leave you with that thought and take you to a case, and then we can come back to this thought at the end of the presentation. So this is a real life case from my practice. A 42 years old lady came feeling plugged up and anosmic, had a surgery done by a fellowship trained rhinologist, so I did not had much worries and concerns about the surgery itself. However, she was initially compliant on her budesonide rinses, despite the fact that she felt that they do not help, but nonetheless, she used to comply on them as instructed. She works from home selling candles mixed with fragrances, so her basically living depends on her being able to smell different odors. She did not want to have any more surgeries, as she felt that she had a good surgery, but it did not work. She was not much tight, lower airway wise, and her allergist actually was already put her on the anti-IgE biologics for 4 months. And this was her scope when she came to the office. As you can see, almost grade 3 to 4 nasal polyps blocking the whole nose, nasal cavity. Again, having had a proper surgery, having being compliant on the topical rinses, polyps and inflammation. What do these polyps tell you? They just tell you that the inflammation is back again. All these polyps are filled with these IL-5s and eosinophils and IL-4/13. These are filled with these inflammatory cytokines, meaning that even though we opened the cavities and allowed the topicals to go in, her sinuses really did not respond in the expected way possible. And then when we usually, after we see these, we like to do the CT scan to see if there's any venue for more surgery. And as you can see, probably rhinologists would know, left shelves that could be a surgical factor for recurrence. You don't see much synechia or mucuses. You just see open sinuses. I'm going to play it back again. You just see open sinuses, full-on inflammation back again. But really, in my book at least, there's no much room for more surgery. Of course, we can optimize a little bit of a shelf here or there, but in general, it looks like a good surgeon. So we usually, at this point, we take the patients to MDT to try to kind of discuss what is the best way going forward. Do we do bigger surgery? Do we start them on oral steroid? Do we start them on biologics? What do we do? So when we look at the labs, her IgE was a little bit elevated, very little bit elevation. Eosinophils were a bit high, over 500. SNOT22, of course, was terrible, around 70. And again, for non-ENTs, the SNOT22, which is usually below 40, is considered reasonable, but anything 40 and above is really considered a bad quality of life. Anosmia VAS score was 5 out of 5, could not smell a thing, and needed repeated course of oral steroid only to be able to smell those fragrances that she had to sell. So if you actually apply the criteria for biologics, and this is what we do in our MDT, she actually ticks all the boxes. She has an evidence of type 2 inflammation. She has a need for systemic steroids. She has a terrible quality of life, cannot smell a thing, and has a comorbid asthma, which is not too bad, but she still has some asthma also in the background. So the decision was to start her on mepolizumab and reassess her back in 6 months. And the reason was that I did not feel that there's much need for more surgery. And her eosinophils were elevated. We have MePo in our center available. So we started on mepolizumab. As you can see, those polyps gone away, but you still can see that a little bit of a polypoidal swollen mucosa here and there. But really no big shelves that need surgical removal. And this is what we usually see post-biologics. We don't always see, I would say we don't most of the time see complete shutdown of the mucosa to inactive state. we see the regression of the polyp size and a little bit of a polypoidal changes here and there, especially at this time point. And the best part was she was feeling great. Her SNOT-22 dropped down from 69 down to 17. However, she skipped her appointment again and came back a year later with SNOT-22 68 again, was not compliant on topical steroid this time, nor on the mepolizumab shots. So CT scan was repeated. She had disease back again. We started her on the shots back again and reassess her in 3 months. And as you can see, whenever she starts on the mepolizumab shots, her inflammation calms down. And this tells you that the answer in this specific individual is the biologics, not more surgery. So I like to mention these studies as it makes a lot of sense for us as surgeons, because our patients ask us these questions, and our colleagues, generally ENTs, ask us these questions all the time. What if we did more surgery? Would that add any benefit? I like to always go back to this beautiful Danish study, which was published in the IFR in 2025. They did a beautiful idea and concept of the study. So they actually studied 58 participants with chronic rhinosinusitis with nasal polyps type 2. And all of these 58 patients had some surgery done in the past. And so what they did is they subcategorized these participants into 2 groups. A group went into a revision surgery and then MePO, and the other group went on MePO alone. And they followed these patients for 12 months. And what they found that the group who had complete surgery, who needed a revision completion surgery and started MePO at the same time, did much better than the group who had any surgery and started MePO alone. And as you can see here on nasal polyp score, nasal congestion score, a VAS CRS score, and SNOT-22 score, the group who had complete surgery and MePO did better on the upper airway outcomes. However, when you go on the lower airway outcomes, ACQ7, VAS asthma score, it really did not affect the results much because it did not show much difference. And this actually tells us a clear message that even though it's a unified airway, but it's not always a unified airway, meaning that in certain points, if the surgery is not very well done on the upper airway, the response would not be the same as if the patient who had a complete surgery done. However, the interesting fact that they started MePO right after the surgery, 4 weeks after the surgery. So currently what we do, our practice is we do, for example, a revision surgery. As you can see here, this is an immediate post-op video before we put our absorbable packs. We usually do a revision surgery, and then we give the patients topical steroids, and then we wait for them to fail, whether medically or whether due to incompliance on medications, and then we start biologics. What I want to challenge, I want to challenge this idea and suggest, again, this is not in any guidelines, but it's just a thought to think about. What if we actually, as you can see, the left-hand side, biologics are in the lower part of this algorithm. What if we combine biologics with the surgery in patients who need revision surgery and have very high load of eosinophilic disease? I see, especially after seeing this Danish study, and there's another Italian study that studied the same concept, that probably if we start the biologics a bit early on after surgery, might lead to better results on the patient journey compared to if we waited for them to fail miserably and then start them on biologics and then put very high expectations. So this is something to think about, and I look forward to the upcoming updates on Euphoria APOS guidelines to see if that can be the case going forward. This was another study from the Italian group, the Australian group, which actually showed another interesting aspect. They actually wanted to see that which factor helps the patient to achieve a sustained control. And they defined the sustained control by a very clear and specific definition. SNOT-22 to be less than 30, modified Del-McKay score to be less than 4, and no need for rescue medications. And they retrospectively reviewed around 160 patients who had any surgery done and were on different types of biologics. And so what they found is that the single factor that really was a significant determinant of whether or not this patient would achieve a disease control was whether or not these patients had a complete surgery done. In this case, they found that the patient who had extended surgery done did a bit better than patient who had a bit of a conservative surgery. However, the message is it did not really differ. This patient was on mepolizumab, dupilumab, or benralizumab. What differed really is that whether or not this patient had a complete surgery, and then according to the single center study, the bigger the surgery, the better the disease control. So again, this stresses on the fact, and I like to mention these studies on a mixed podium, mixed audience podium, so that everybody understands the importance of complete surgery. When we really stress on complete surgery, it's not just because we like to do surgeries as surgeons, but because it actually makes a lot of difference. And we know this from our own clinical experiences, and the literature shows it really crystal clear. So when the surgeries were complete, it really did not matter much statistically whether the patient was on anti-IL-4, 13, or anti-IL-5, but what mattered was whether the surgery was complete or not. And this was another post-hoc analysis, and I'm going to finish with this trial, that actually showed another interesting fact. The same Synapse group did this post-hoc analysis, and they found out that the number of patients, the effect of mepolizumab was much better in patients who had one good surgery compared to patients who underwent repeated surgery on and on. So if the patient would have one good surgery and start mepolizumab short after, did much better than patients who had repeated surgeries and then started mepo again. So the outcome regarding nasal polyps were better in the first group. So this tells us again a clear message that one good complete surgery followed by mepolizumab probably a bit early on, rather than waiting for them to fail or waiting for them to have multiple surgeries, would be a bit better, especially for patients who are candidates, especially for patients who we expect that they would not do good, according to their radiological scores, according to their laboratory findings. So there's a lot of work needs to be done, publications-wise and also consensus-wise, regarding what is the best timing to start these biologics. Is it really after they miserably fail, or is it when we predict them to fail and then start them right away on biologics? With this, I think that we need to think about sinusitis definitely in an endotype-based approach. Days of polyps, non-polyps have gone long passed away. I think it's all about the endotype these days. If surgery is not helping, as the literature shows, do not keep doing again and again terrible surgeries, because that might have some effect on the efficacy of biologics when needed later on. So what is needed is one good surgery, probably some extended surgeries if there is an indication, and then probably start them a bit early on biologics, rather than waiting them to fail. And I just want to point out that this is not a recommendation. It is yet not mentioned in any guidelines, but these are the things that we predict that might come in the guidelines based on the literature that we have and based on our clinical experiences. With this, I think I'm done. Thank you so much for giving me the chance, and back to you, Dr. Balkhi.
Thank you so much, Dr. Badr. Allah يعطيك العافية, for this excellent and very practical lecture. As usual, having visual insights and showing people like what do you see and what's your angle of as an ENT. It's really, really helpful to comprehend all the disease process. You brought into the discussion from biology that we have been discussed before, and the evidence you showed to us to the real clinical practice, and we have to decide how to assess patients, how to escalate the therapy, how to measure meaningful response. I think one of the really key messages from your talk, managing CRS with MP shouldn't be depending only on what you see endoscopically. Patient suffering, patient feeling multiple things. SNOT 22 really showing us the measure, basically the effects on the smell, obstruction, sleep, fatigue, and quality of life. And you clearly mentioned very important thing, and I'm happy that it came out from an ENT perspective, because sometimes I hear from ENT colleagues that giving only one steroid or two steroids per year should be fine. Actually, these burst steroid, even for 3-5 days, is not really good thing. And cumulatively, it's as equivalent as if you're giving patients steroid on daily basis. So do not assume steroid is safe. It's a good medication in a certain situation, and it was given when we didn't have much an options. But now we have to really think twice before giving a steroid. Your lecture is very important. I highlight the importance of the structural tools that need to be used when you assess a patient. I think with that, I would like all the speakers to come to the stage, because we have really good questions and excellent questions. It's going to be a very interesting discussion, and I want to see how we're going to tackle these questions from the audience, as well as I have a couple in my head. I want to ask all of you as well. So, Dr. Arand, are you with us? Dr. Yazid?
حياك الله دكتور علي. تفضل.
ممتاز. So it's good. Now, I think we covered this question, but I want, as a standardization, as how we, from each point of view, as a summary for this talk and this scientific meeting tonight, how we can combine surgery and biological therapy for better patient's outcome. Having surgery, having advanced therapy like biological therapy, how we can combine them, how you approach. So from each one of you, I just needed in a couple sentences so we can have a summary for what we just discussed over the last hour. I will start with Dr. Badr, who ended up tonight.
Yeah, thank you. I think a very important question to start the Q&A session with. In my opinion, I don't want to take a long time, but in my opinion, the way to combine or the way to decide, do we need only one surgery or biologic, or do we need a complementary approach, is the MDT. I think having an allergist next door, having a respirologist next door is very important to determine the clear venue when biologics need to kick in, or if further surgery needs. I remember listening to you in certain meetings that you actually sometimes agree with the surgeons that this patient does not need a biologic, he needs a better surgery. And so I think to combine both, the way to go further.
We lost your mic. It came mute.
Yeah, so I was saying having an MDT with a surgeon and a medical rhinologist, if you may, sitting together would be the best approach to see if a certain patient needs a combined approach. And I completely agree with what you said in the beginning of your comment on my talk. We really need to keep the patient in the center of our focus. sometimes we as surgeons try to expand our criteria of what a nice surgery looks. And we have a very clear classifications of what means that the patient had a complete surgery. We had clear scores, we had clear radiological scores, and we can tell when a patient did a good surgery or not. But I think before deciding to put a drill in the patient's head, we need to really carefully think, is that really needed, or biologics can fix the problem? So having an allergist to give an opinion on this would be very helpful to decide how to combine them and when to combine them.
Great, great. Dr. Arand, in 2 sentences?
Yes, dear. I think we go back to the patients again. I think it's always a good idea, and many of guidelines reflect that at least one surgery has to be done, one good surgery has to be done before. And I think deciding on the biologic should not take long after that after the surgery. So because if you think that the patient is coming back with the polyps again and the manifestation is coming back, it will be a waste of time. Said, let me do the revision, maybe it will work next time. So maybe try this time to combine what you have done with a biologic and see, maybe it will prevent the patient from having another surgery. Because from my clinical observation, actually, I have noticed that the more the surgery has been done in this patient, the chances of regaining their smell with the biologics becomes less and less. I think a lot of fibrous tissue is there with the healing, and I don't think the fibrous tissue has these neurons or the nerve cells that lead to the smell. In addition, sometimes you might put the occasionally you might need to put the biologics before the surgery, and that's if the patient have other comorbidities that dictate that for that reason, not necessarily for the nasal polyps. Okay, so I think or the patient has a complete contraindication for the surgery, like extremely morbidly obese with the cardiac disease, and then you might ease down the inflammation with the biologic, and if he improves, then the patient can go for surgery. So I think it's patient by patient, and always the combined approach is good, but we don't need to go too early before the surgery for those who doesn't need it, or go too much with the surgery for those we can prevent further surgery with the biologics.
Okay. Dr. Yazid, anything to add, or what do you have in your mind?
Well, nothing much to add to Dr. Bader's answer from ENT perspective, but since MDT was mentioned,
go ahead. Sorry.
Since MDT was mentioned, just want to highlight also the other importance of MDT is some patients respond of biologic in other comorbid conditions such as asthma, but not necessarily in nasal polyps. So having the MDT, deciding which biologic works best for both conditions together, switching biologics is also another, highlights the importance of having an MDT.
Sounds good. All right. Now, I have to highlight, mashallah, tabarakallah, our attendance more than 300. And we have a very good amount of physicians who's attending today who are primary care physician, or they are family physicians or internists. They have one question that comes to mind. What's the role of primary care physician, either internists or family physicians, in the management of chronic rhinosinusitis with MP, as well as their role in biological therapy, would say? I want to hear, to be honest, I want to hear the different perspective. I want to hear from all of you, where do you think where they should be, and how we really can help in the center of the patient and the management of these patients. So, Dr. Bader?
Such an excellent question. I think primary care physician, it all starts with the primary care physician, or at least it should start with the primary care physician. I think even though we acknowledge the fact that primary care physicians do not have the luxury of having a scope, the luxury of even requesting a CT scan in the primary care center. Most of the primary care centers do not even have a CT scan. Some of the centers which have dental clinics might have a cone beam, but I mean, speaking at Saudi Arabia, most of them do not. So I think the key part that, from my own point of view, is the fact that they really need to differentiate. They need to tease out the patients who have sinusitis with nasal polyps from patients who have just an allergic rhinitis, because both of them will have blockage. Both of them will have congestion. However, there are few symptoms that might be associated with the sinusitis with nasal polyp patients, which usually are not there with allergic rhinitis patients, like sense of smell, loss of sense of smell. So allergic rhinitis patients will be plugged up, will be having some thick discharge, but you rarely see allergic rhinitis patients with complete loss of smell. They might tell you that my smell decrease is not as good as that, but if you dig down in the history and you ask them, like, can you smell a coffee? Can you smell perfumes? They'll tell you, yeah, I can smell. So a patient usually with a grade 4 nasal polyps who would have complete blockage of the nose would not usually smell their coffee and their perfumes. So taking a good history, teasing out allergic rhinitis patients from sinusitis with nasal polyps is a great rule for family physicians and general practitioners.
Good, because actually one of the questions in there was talking about how you will diagnose and what other sinusitis that you should think about it. So, Dr. Yazid, what do you think?
Well, back to the beginnings of the standard treatment for these patients. So most of the patients coming from primary care, when they come, we check for the compliance on treatment, the duration of the treatment they have received, did they use it properly. So I will stress on the point as a primary care provider, and basically when you prescribe the patients, for example, intranasal steroid, the mainstay of treating these conditions, stress on the compliance. So most of our patients, they think they will see the difference in a couple of weeks. That's not true for chronic sinusitis. So they have to stay on it, compliance, for at least 6 weeks. They're also concerned about the side effects of intranasal steroid, like systemic steroid side effects. So they have to basically counsel the patients properly that this is a safe medication, the absorption rate is very minimal, it's very safe. So basically teaching the way to use it, enforcing the point of compliance, duration of treatment expected is very crucial.
Okay, great. Dr. Laurent, anything to add to this point?
I think the role of the primary physician always is important because they are the gatekeepers. And I think they have to look for the unusual signs. If the blockage doesn't respond to any type of a treatment, I think, and also they can give lots of steroids, and that's also the problem. So if we should probably come out with some even guidelines for the primary care physician. If your patients, for example, had loss of smell that is irreversible and it's not, you had to give him steroids for that, or if there's a persistence of the congestion on the nose, despite even using nasal sprays and being compliant on it, I think the patient needs to go and see an ENT surgeon, because there must be a reason for that. So basically, that's similar to what asthma. You have too many exacerbation. The answer is not giving too much steroids. The answer is refer him to somebody who can control the disease in a better fashion rather than just spending steroids. So I think having some guidelines for them for referral is very important.
If you allow me, Dr. Adib, just to stress on the point of using oral steroid, it's being underestimated really in the primary care level. So it's even, I've noticed it's being even given in acute sinusitis or even common cold patients with severe nasal congestion. So oral steroids should be really restricted for, certain type of patients. So underestimating using of oral steroid, even like you mentioned, low dose, short course, is should be considered.
Great. I want to add a few points, if you allow me, specifically about how you differentiate between type of sinusitis. I mean, one of the things you could, if the patient has recurrent symptoms, you can get CT sinuses to show exactly if there is a sinus inflammation. That's not going to tell you if there is nasal polyps, but it's going to give you a hint of sinusitis. And probably, if you have good radiologists, they're going to show you if there is nasal polyps or not. But to be honest, you can use the otoscope. Use otoscope, get in inside the nose. If it's big enough, grade 3, grade 4, you will see the polyps. You're going to see it clearly like a grape coming out from the middle meatus or from that part of the nose. So it's just simple things. You can stick it in there. The other thing, the type of discharge. Not every discharge coming out, it's a purulent discharge or it's an infectious discharge. Actually, the type 2 inflammation discharge, it's gooey, sticky, mucinous discharge. So these type of things make you think towards type 2 inflammation, probably CRS with MP. So these clinical signs that really can give you a hint. And always have good collaboration with colleagues from ENT side and from allergy side. So when you have a patient, you can send them to refer those patients to give you instant feedback that helps your own patients. So I will sum up two questions because I see these practices and I want to have the view or the point of view of these things. When we talk about medications, before we dig in deeper about certain things, but I see still a lot of people they're using montelukast or leukotrienes inhibitors among ENT doctors as well as among primary care physicians. In a one word, from an ENT perspective, and I'm going to see it also from immunology perspective. Do you think that's an appropriate treatment to treat type 2 inflammation patients with evidence that we have? Is it something that we just throw into the patients, or probably you shouldn't going to have a good effect? And if it's going to have effect, what subset of patient you might think is going to have good effect on? Dr. Badr and Yazid, one of you. Who's patient? Dr. Yazid?
So from evidence point of view, there is no clear recommendation to use it, but it remains an option and good additive to use, but it's not basically one of the standardized treatment for CRS with nasal polyps patients.
Good.
But remains an option as an additive measure.
But would that delay your advanced treatment? That's the problem is you're gonna keep throwing these medication instead of going to. Okay, good. Dr. Rand, from allergist standpoint of view.
Actually, yes, very little to add. But on the other hand, I think the aspirin exacerbated respiratory disease patients might be the subcategory that leukotriene inhibitors might give. More than expected or more than the other subgroups.
Yes. So it's only in subset of patients where basically might have some beneficial effects because it's working on leukotrienes. Now, this question to Dr. Yazid. As an ENT, when do you stop calling CRS with MP? It's a local surgical disease, and I have to start more treating the chronic inflammation of airway rather than just doing a surgery?
Well, the answer is simple. We have a guidelines to follow. So if you have a patient who's received the standard of treatment, compliant, had the surgery, that received the proper post-op topical treatment, failed, then this is where you think outside the box. And when we say surgery, we say complete surgery, like Dr. Badr has mentioned and emphasized. So complete surgery is very important, and it's very easy to assess patient had a complete surgery or not. So we do a CT scan post-op, If the surgery is complete, disease is recurred, this is where you should think outside the box and think about treating the underlying inflammation with biologics.
Okay, that takes me to better. During your talk, Better, you mentioned very interesting concept. They say, I would rephrase it. You call high-risk patients or the patient at higher risk of recurrence. What's the criteria that you may, from your practice and from the data, it suggests that this is high risk patient, and when you do the surgery and you do full surgery, that you have to closely follow up these patients because your concern for recurrence is going to be high, and you want to intervene early on before recurrence happens.
Excellent point. I think this is one of the very important questions that we still don't have a clear, agreed upon answer on, which are the predictors. What are good predictors? That's a very important question that we keep asking ourselves. How can we not get this patient to miserably fail, and how can we catch the ones who would really need biologics later on and probably start them early on? Probably. So I think there have been some studies who actually studied predictors of recurrence of disease and so forth. So I would probably categorize it, if you may, into different categories. So starting from history, patients with comorbidities is definitely a very high predictor of recurrence of the disease and nasal polyps. For example, if a patient is coming with a grade 2 nasal polyps bilaterally, so overall grade 4 nasal polyps, with a background of uncontrolled asthma, is much different than a patient is coming with a grade 2 nasal polyps without asthma and without allergy to aspirin and NSAIDs. So this is number one. Comorbidities is a big predictor that this patient probably might fail down the road. The other thing is, of course, having the criteria of NSAIDs allergy or aspirin allergy is one of the big predictors that these patients might not do very well. The other thing is age group. I see the younger the patients, the heavier the disease. For example, if a patient is coming with a full-on grade 4 nasal polyps bilaterally at the age of 22, I look at them very differently than a patient who comes with a full-on bilateral nasal polyps that started around 2-3 years ago and their age is 52. So early age is something also a predictor, in my opinion. The other thing is when it comes to examination, I show a lot of videos. So probably you see in some of my videos that a lot of these polyps, the look of the polyp itself, regardless the grade. I mean, of course, the higher the grade, the more severe the disease is. But also the look of the polyps. A polyp which looks really transparent and you can actually see each and every blood vessel into it is very different than a polyp which looks a homogeneously red fibrotic polyp with the very angry fibrotic mucosa around it. So the red fibrotic polyps are usually more stubborn than the clear, nice, transparent polyps. The next step goes also radiology. The higher the disease, the higher the recurrence, as well as the eosinophil count and the type 2 surrogate markers that we have, the IgE and eosinophil levels. All these elevated markers would predict or indicate that the patient is likely to recur.
Okay. This is a question to Dr. Rand, because we have only 4 minutes or 3 minutes left. Before I close up with one question, because it's very interesting, and we encounter these questions nowadays in our clinics. But this question, Dr. Rand, is there any relapse after surgery? Yeah, patient had surgery, had full functional surgery. Also, you put the patient on biological therapy agents, but they still relapse despite being on biological therapy. Do you see this in your clinical practice? And if you do see those patients, what do you think and what to do in these patients?
I probably didn't see a relapse, but I did see 2 patients, and we do have a lot of patients. Actually, currently in our hospital, we have around 1,400 patients on dupilumab 38% of them are actually for chronic rhinosinusitis with nasal polyposis. Most of them almost all of them initiated by us in allergy because we were the ones who were prescribing it for, and it was in a poster in the European Academy of Allergy, actually. Those patients on Dupi for nasal polyposis, almost 90% of them on dupilumab for nasal polyposis. 2 of them actually did not improve, as if we have done that made me think that these 2 patients probably are actually not type 2. Probably they are another type. For some patient, I did not even start, for example, Dupi, and they did improve a little bit, but they did not improve dramatically, and their actually nasal polyps were in context of AGPA. So our choice was guided by the underlying disease, not by the nasal polyp itself. So they did improve, but it was not a dramatic that you would expect, because that disease type is different. So I think this will tell us same. Not everybody is type 2. Probably the vast majority, but there is type 1, like with the AGPA, there is also type 3 and other types. So we have to always keep it in the back of our mind.
That's a good thing. That's usually, if the patient is not responding to surgery and treatment, you have to think there is something else. And usually, and even one of my dear colleagues, Prof. Osama, he always said, when you see nasal polyps, think it's something that probably is not a good thing. You have to rule out bad things. Not everything it's a just inflammatory polyps, even though it's the most common. You have to rule out the most serious ones. Now, I wanna finish up with this, because believe it or not, I know this is we see it, and I get this question all the time, and I really know these comes from patients, and I want your feedback on this, because a lot of physicians here, they get these questions, and they need to really scientific answers, at least from experience or from scientific perspective. We witnessed COVID-19, and we all lived that era. And based on our practice, post COVID-19, let's say the percentage of chronic rhinosinusitis nasal polyposis went up. And I would say this is what I see in my clinical practice. What do you think about, is it COVID-19 or infection in general? And even if the patient, you've seen a lot of patients, they've been having surgery before the COVID era, but the relapse happened after COVID. So from ENT perspective, Dr. Badr and Dr. Yazid, have you seen this? And if you've seen this, how you really communicate the message with your patients, try to educate them? Is it the COVID, or is it because of the infection itself? What do you give from this? And I know always the vaccine effects on all these things, but I really want a good answer that more educational, informative, that helps the audience when they have this question comes to their clinical practice, they can answer their patients. Dr. Badr, do you have any answer or comment on this?
So I just want to make sure that I heard it right. You said that post-COVID-19, the incidence of sinusitis with nasal polyps went up?
Yes, at least what I see from my practice. I don't have evidence about this, but this is probably a physician also notices those things.
Yeah. So what I can share from ENT experience, that during COVID era, we really had a big surge of not inflammatory sinusitis. We had a very concerning surge of something called invasive fungal sinusitis, which is a very serious and very different disease than sinusitis and nasal polyps. However, I do see from time to time that patients correlate COVID-19 as the starting point of their struggle journey with polyps. This might have some truth into it. I am not aware, honestly, about any data in rhinology literature that actually shows a clear link between the two. Almost always a viral infection has been shown in multiple epithelial studies to be a starting point of a chronic sinusitis with nasal polyps journey. Is it exclusive to COVID-19? I don't know, and I don't think we still know that answer. But I would share the fact that probably because there was a much focus on COVID-19, patient related to that, but I don't have a clear answer to whether if it increases the incidence.
Okay. Dr. Yazid, do you have any things to add to this?
Nothing to add. To my knowledge, there is no clear evidence about the relationship between the two conditions.
Dr. Aran, we're going to close with you.
But definitely loss of smell. I'm sure you have seen patients with loss of smell. And I think it was related clearly to the virus. Sometimes it was the first manifestation in some patients.
Yes, of course.
When I had my COVID myself, I lost smell for 1 day, and I just felt with the patient that you don't smell, you put a perfume and you don't smell anything. So it's something serious, and I think if you have it for more than 1 day, it will be affecting your life big time.
Yeah, I would say one simple thing. I completely second what Dr. Badr mentioned. It happened. It was pandemic. A lot of people got infected, and it's one of the viral infection that we know viral infection can activate or demethylate certain genes, and we've seen it in our clinical practice where patient had quiescent asthma or quiescent nasal diseases after childhood, that it's been reactivated, both COVID or both viral infection. And that's usually what we hear in our clinics. We say patient, he says, oh, I got this infection, after that I developed asthma or I developed sinus disease. So it's because of viral infection. That's the main activation for gene methylation and demethylation. So it's rather than a direct correlation between the COVID infection or the vaccination. It's just a genetic predisposition in lieu of viral infection. So I think we came.
If you allow me, Dr. Adib, just to deliver the accurate message. So post-viral anosmia after COVID is not basically the same mechanism what happens with sinusitis, just for the audience.
Yeah, definitely. That was a different phenomena. But I was talking about type 2 inflammation activation post-viral infection. So with that had been said, we are 5 minutes past our time. I would like to thank, first of all, the audience being up late with us tonight in this wonderful scientific meeting. I would like to thank all the speakers for their valuable input, very valuable sharing experience and being with us and sharing their knowledge with us. I would like also to thank GSK for hosting this wonderful meeting. And with that, I would conclude our tonight's meeting and hopefully wish you all a wonderful night. The last thing I want to say, take action before recurrence take over, because be careful with your patient, especially if you had good surgery, and be proactive, not to be reactive. Thank you so much, and I wish you a wonderful night. Assalamu alaikum.
Assalamu alaikum jamia, and thank you all for being the late with night and for this nice meeting. Thank you so much. Thank you, JSK.
Thank you.